Good afternoon, everyone. My name is Hanna Oltean. I'm the zoonotic disease epidemiologist in Washington State. So I work really closely with our public health veterinarian, Dr. Ron Worley, and our entomologist, Liz Dykstra. So a lot of this work is done in collaboration with them, and I'd like to just acknowledge them at the beginning. So by way of brief introduction, here are some tables of zoonotic diseases that we record information on and that are reported. These tables are for the past 2 years, 2015 and 2016. So you can see we do have cases of brucellosis. Those are all travel related. We don't have any endemic cases of brucellosis recently reported in Washington. We have cases of coccidioidomycosis that we track. I'll talk about this in a little bit more detail in this presentation. Give you an update on what's going on with Cryptococcus gattii in Washington. We track Hanna virus, leptospirosis, and Q fever. I won't really get into those today. Tularemia says 0, but we just had our first case since I pulled this data 2 weeks ago. So, and then of course, outbreaks with zoonotic disease transmission. We have had 2 salmonellosis outbreaks in the past 2 years each, and then in 2015 we had a big outbreak in Whatcom County related to children attending a dairy festival. This is a look at our vector-borne disease. I also work on vector-borne disease in Washington State. I'll talk a little bit about Lyme disease and West Nile virus today. We have fairly stable numbers over time, as well as a little bit about travel-related arboviral diseases such as dengue, chikungunya, and Zika. So I'll start by talking about valley fever or coccidioidomycosis in Washington. So this is really an emerging infection for us. The first cases were really identified in 2010 and 2011. There had been anecdotal reports of cases that providers thought may have been locally acquired in Washington State, but these people always had remote travel histories to areas where the disease is endemic, such as southwestern United States, and so it had never really been pinpointed to Washington State until some soil from some exposure locations tested positive for Coccidioides immitis in Washington. So one of those specimens was cultured and a unique clade was identified, so we are certain that there is Coccidioides immitis of a unique clade in south central Washington. And we've had 9 cases that are locally acquired that we have identified to date. So you can see this map here in gray are the counties where we've had cases, and the pink circles represent where we've had soil that's tested positive. We've really had limited soil testing to date, so those are actually the only 2 counties that have been tested, and both have been positive. So that's a little bit misrepresented there so far. So in Washington, as I mentioned, we've only had 9 locally acquired cases, so we have very small numbers. But we do have higher hospitalization rates among these cases than would be expected. So 2/3 of our cases have been hospitalized compared with 40% nationally in the United States. And we also have already had 1 death out of those 9 cases, and so that's also unexpectedly high. So, and we've had rare disease presentations. So cocci normally presents as a respiratory infection, usually very similar to something like community-acquired pneumonia. And things like cutaneous lesions or infections or meningitis are very uncommon, and we've already had a case of each of those in Washington out of our 9 cases. So the question is whether we have a very rare pathogenic strain in Washington or whether our surveillance is just doing a poor job of picking up cases. And we think the second is true, that we are identifying only the most severe cases, mainly due to lack of awareness and lack of testing in our community. So we have a lot of different projects ongoing. CDC is very interested in what's going on in Washington on this, and so we are doing a lot of enhanced provider education, so doing targeted education to providers in the communities that are affected, as well as enhanced public education. So we have done a couple of town hall meetings, lots of media releases. We've created some pamphlets and brochures for patients, that type of thing. We are attempting to implement an active surveillance project with a single hospital, so essentially creating triggers for testing for cocci to see if we can figure out among people who present with symptoms consistent with cocci how many are actually positive. We are working to gather commercial laboratory data on Washington residents to understand testing practices in Washington and to better understand our prevalence based on that. And also in the very, and many of these are in the very beginning stages, we are working on a knowledge, attitudes, and practices survey, so we can sort of get a baseline of where our providers are at, see if any of our educational efforts are really making a difference at this point, and identify areas for improvement. We also have a lot of ongoing soil sampling to better understand the geographic range in Washington, as well as some ecological niche modeling, but we really need more data before we can really produce a robust model for that. Our public health vet is working on a pilot canine sero survey and trying to assess the impact in dogs in the affected area as well, since dogs can be affected. A look at Cryptococcus gattii. So C. gattii has really remained stable in Washington state with 1 to 7 cases reported per year. We mainly see cases along what we describe as our I-5 corridor, so that's just the north to south western side of the state there. And we do surveil both humans and animals, so you can see in blue on the map are human cases, the gray dash marks are animal cases, and the pink are environmental positives. We really don't do a lot of environmental testing at this point, so this represents a little bit older data. And we are not pursuing any active surveillance projects related to C. gattii at present. So as far as arboviral disease, this has been a big hit for us this year. It's required a lot of work to implement surveillance systems for Zika virus. So mirroring what's been seen in Central America and the Caribbean, we've had a spike of chikungunya cases in 2015, followed by a major drop-off here, and then this big spike of Zika cases in 2016. So we've had almost 60 cases in Washington state today. All of those are travel associated, and none of them are sexually transmitted. So far. I don't want to jinx myself. And we do think that there has been an increase in testing in this past year for people presenting with arboviral disease symptoms because of the concerns around Zika virus, as Dr. Morsh had mentioned. Washington State is participating in the CDC US Zika pregnancy registry that tracks pregnant women with any laboratory evidence of infection. We have 6 women enrolled in the pregnancy registry. And CDC is also conducting a persistence in semen study to better understand viral shedding in semen, and we have about 10 men enrolled in that study. We are in the process of implementing testing at the Washington State Department of Health, although that's not complete yet, so we have been working mainly through CDC and Minnesota Public Health, who is assigned as our reference laboratory. And you may be aware that FDA is in the US is now requiring blood centers to screen individual blood donations for Zika virus, and that actually went into effect this week, and so we have 4 blood donation centers, agencies in Washington that will begin screening this week, so it will be very interesting to see what we see from our blood donors. A look at West Nile virus, you can see, so this first graph shows over time from 2006 when the first case was identified in Washington through 2016. So we did have a big year back in 2009, but in the past 3 years we have had more cases than previously. Not entirely sure what is causing that, although it likely has to do with some of the weather patterns we've seen over the past couple of years. Probably greater awareness as well as contributing. And then when we look at onset month, last year, 2015, we had a very early season, so we saw cases in July and August, which was abnormal, and normally we see more cases in August and September, which is what we saw this past year. This is a look at our human cases by county of exposure. So as described in the first presentation of the day, we did see a little bit of an eastward and northward shift in our human cases. That was corroborated by our colleagues in Idaho. They also saw more cases in the Panhandle this year. And so for our West Nile virus surveillance, we have passive reporting for West Nile virus disease and electronic laboratory reporting from labs, as well as blood centers who report asymptomatic infections. Mosquito surveillance, we do have mosquito control districts in Washington, and then our Department of Health does some trapping around the state. And mainly horses are reported from the Washington State Department of Agriculture. So you can see this first map here is the distribution of mosquito trapping events by county in Washington, so it's really concentrated mainly in our south central part of our state. And then this is a map of infected horses, birds, and mosquitoes. So again, for 2016, you see that sort of northeastern shift there. So I want to touch briefly on Lyme disease in Washington State. This is something we've been exploring more. This is a look at our cases over time since 2005 by exposure location. So in red you see cases that are exposed outside of Washington, so mainly in endemic areas in the Midwest and upper Northeast of the United States. In green you have people who have unknown exposure location, and then here at the bottom are very low prevalence of people who are exposed in Washington State. This represents both our probable and our confirmed cases over time. However, when we're thinking about Lyme disease in a very low incidence area, for our confirmed case definition, someone has to have both clinical and lab evidence of disease, because no counties in Washington are considered endemic, and the CSTE case definition takes into account whether or not an area is endemic. Whereas probable cases just have to have a physician diagnosis and laboratory evidence. So that causes a little bit of problem when you have physicians who are very willing to diagnose Lyme disease. So if you take out just those 13 confirmed cases, so those are people who both have clinical signs and symptoms and have laboratory evidence, that gives us a much smaller number over a 10-year period. But when we delve into their history, we see that 8 out of 13 of those reported a tick bite, and the remaining 5 reported exposure to known vector tick habitat. And so there's good evidence that those are very likely true cases of Lyme disease. So that leaves our yearly incidence at 0 to 0.04 cases per 100,000 population. So we are working, and by we I mean Dr. Liz Dykstra is working to test Ixodes pacificus ticks in Washington. And this sampling has been going on since about 2010. There are 2 different types of sampling. So these include targeted tick sampling around known exposure sites of human cases, as well as systematic tick drags conducted at several different sites around the state. We also have partners who contribute tick submissions, and these ticks are tested for Borrelia burgdorferi at several different locations, including here at BC CDC. So when we look at our detections over time, on average, we have 1.7% positive Borrelia burgdorferi among Ixodes pacificus ticks. And we did, in the past year, subspeciate these to check and make sure that they were sensu stricto and not sensu lato. And we did identify Borrelia burgdorferi sensu stricto, so we do have the pathogenic cause of Lyme disease. And we also had an additional 8 detections in other Ixodes species that are not thought to be important vectors. So when we overlay this data between the human and tick detections, you can see in the blue color we have counties that have human cases identified. And then in purple you have the detections of positive ticks. So we only have 1 county right now that's overlapping as far as human cases and Ixodes pacificus Borrelia burgdorferi positives. And then when we look at other tick-borne pathogens, because we also do other testing as well, but I can't really fit all of the explanations into a short talk, we do have detections of Anaplasma phagocytophilum in Ixodes pacificus, as well as Borrelia miyamotoi, which is a very recent detection. We have not detected Babesia duncani or Rickettsia rickettsii in tick populations in Washington. And to date, we don't have any human cases of anaplasmosis or infection with Borrelia miyamotoi identified in Washington. But we do have reports of babesiosis cases with exposure in Washington, as well as cases of Rocky Mountain spotted fever identified in Washington. Other ongoing projects, I did want to mention this because I think this is a really important outcome of increased collaboration and exposure to our partners across the border. So the BC CDC Communicable Disease Control Reportable Zoonoses Guideline, that's a long name, we found to be a very useful document for modeling how to have good partnerships between epidemiology and departments of agriculture, departments of fish and wildlife. And so we're working to establish a similar standard in Washington, so we're creating a similar document for use in Washington. We're working to create a standard reporting form so that we can track cases that are reported cross-agency. So hopefully next year I'll be able to have a slide about cases that were reported to us or cases that we reported out. But ideally, our envisioning of a perfect world future situation would be linked surveillance databases, which seems like it's a few years away at this point, but that is our ideal moving into the future. So again, I'd like to acknowledge my very many colleagues who work on these projects, and thank you for your time.
All right, Eleni. Thanks, Hannah. That was a great overview. I have a comment and a question. My comment is, it's funny that you say that you appreciate the guidelines on reportable zoonoses, because we actually modeled our surveillance program on yours. when we had Myra Leslie here, who had helped set it up in Washington several years ago. My question was around West Nile virus and mosquito testing. So like you, we discontinued bird mortality surveillance several years ago, and then about 2 years ago we discontinued mosquito surveillance, because we found that it wasn't providing us an early warning, and it wasn't providing any further information on the presence of West Nile that we didn't already know. We were anticipating it would present in a particular region at a particular time of year, and the mosquito surveillance wasn't providing any further detail. And I wondered about how your mosquito surveillance is assisting you in an early warning or other other function, particularly in a year like 2016, when the shift occurred and the cases are happening much further east, both in BC and in Washington, than they had in previous years.
Well, so you sort of answered the question for me there. So I agree, and we have had conversations, because we agree that mosquito surveillance does not necessarily provide an early warning, and it doesn't necessarily provide an accurate representation of when human cases will begin occurring. So for example, this year, 2016, we had our earliest detection of West Nile virus in mosquitoes ever. But our human season was very much on track with normal. So we had our cases in August and September, despite a May detection of West Nile virus in mosquitoes. And so I agree. I think there are two pieces that it assists us with, and one is geographic spread, so understanding, like you said, a shift in where cases might be occurring, and we did see that mirrored in our human cases. And then the second, and this doesn't necessarily require testing of the mosquitoes, but I would say it really helps us track what mosquito species are present and the geographic distribution and the time of when those populations are present. And especially when you have the arrival of something like Zika and people are wondering what data you have on mosquito species, it's really assisted us to have that robust information to share.
Any other questions for Hannah? No? Well, thanks very much.